Hello, everyone. I'd like to thank the organizers for giving me this opportunity to give my talk at Avatar 2021. The topic of the the topic I was given for today was the current understanding of bone metabolic disorder, and I have taken a bit of liberty in modifying the title to Renal Bone Disease 2020s, an evolving challenge for the nephrologist. What I hope to do today is outline some of the challenges that we still face in renal bone disease and talk about this in three major themes. The first is to understand fractures and osteoporosis in the context of CKD MBD. The second is to understand the importance of bone turnover and the importance of why we should understand it in the context of patient care. And the third is to try and caution my fellow nephrologists against the specter of renalism. So let's start with the risks of fracture and bone fragility in patients with CKD MBD. We are all very familiar with the fact that patients with chronic kidney disease have an elevated risk of fracture. This risk of fracture um, increases as severity of the kidney disease worsens, uh, as well as across the age spectrum, which is very parallel to what we see in the general population without kidney disease. And having a fracture in a patient with kidney disease is not trivial. After a hip fracture, patients with chronic kidney disease are twice as likely to die, have longer hospitalizations, more likely to require institutionalization, and have higher healthcare expenditures. So let's take a step back over here and try and understand what the determinants of bone strength are. So, when we look at a man made weight bearing structure, the model parameters are conceptually and computationally well known. But when we jump to the human body, the complexity and dynamic nature are harder to comprehend. These graphics show a 3D reconstruction, and these show the histological progression when a person is losing bone. In the histology, we see progressive loss of trabeculae, decrease in thinning of the trabeculae, and a decrease in trabecular connectivity. When we look at the cortex, we see thinning of the cortex and we see increasing porosity of the cortex, and all these translate into a decrease in bone mass as we go along the spectrum. Now, this decrease in bone mass can easily be measured as bone density with standard DEXA instruments. However, bone density is not the only determinant of bone strength. There are a whole bunch of other parameters such as bone turnover, bone mineral matrix properties, bone quality, and bone microarchitecture. And all of these are not routinely available for clinical measurement. We can measure bone turnover basically on histology, and we can measure bone microarchitecture using a high resolution peripheral quantitative CT scan, but HRPQ-CT at the present day is still in the realm of research. Examination of bone mineral matrix parameters and bone quality still are confined to the realm of research. So when we look at bone mass or bone density in the general population, we know that there is a predictable relationship between the change in bone mass over time across the age spectrum, and the decline in bone density has a predictable relationship to the risk of fracture. And indeed, this is the relationship that is incorporated into calculators such as the FRAX, which gives you the probability of fracture in the over a 10-year period. Unfortunately, in the nephrology community, for a long period of time, we had little faith in measuring bone density. Perhaps this was not such a good example of therapeutic nihilism. Indeed, the 2009 KDIGO guidelines did not recommend DEXA testing routinely in this population, although if you think about it, patients with CKD stages 3 to 5 probably fall into the high-risk age group of osteoporosis as in the general population. However, with more accumulation of data, the more recent 2017 guidelines does recommend DEXA testing in patients with chronic kidney disease. So, in terms of testing for bone density in patients with chronic kidney disease, where are we? We now admit that a patient with chronic kidney disease who has a low bone density carries the diagnosis of osteoporosis and therefore a higher risk of fracture. We know that a low bone density predicts fracture in patients with chronic kidney disease, just as it does in the general population, although the relationship may not be as precise. The 2017 KDIGO guidelines recommends bone density measurement if results would also alter treatment. However, as we interpret bone density, the interpretation has the following caveats. We have to remember that bone density, as we measured with a DEXA scan, has a poor correlation with bone histology. Therefore, aspects that we might see in the bone histology are not predictable based on a bone density measurement. Bone density has no role in assessing bone turnover, and we have to remember that fracture risk is elevated even in the setting of normal bone density. So, how do we reconcile a low bone density in patients with chronic kidney disease, a high fracture risk, as well as the caveats where there may be a change in turnover and there may be a change in fracture risk despite normal bone density? We are able to reconcile this if we consider renal bone disease as a form of secondary osteoporosis. And if we remember that having a secondary cause such as CKD MBD is always a risk multiplier for fracture. It's often associated with abnormalities of turnover and mineralization, and these abnormalities often translate to bone quality and poor bone quality and microarchitecture. The mineral metabolism abnormalities that we encounter in chronic kidney disease would contribute as well, and they would influence treatment decisions and response, as well as serve as markers for monitoring. The structural correlate of secondary osteoporosis here is the fact that cortical bone is more affected than trabecular in osteoporosis that we encounter in the setting of CKD MBD. And of course, through this entire through this entire understanding, we have to incorporate the fact that age-related factors cannot be dissociated from the osteoporosis that we see associated with chronic kidney disease. It's interesting that in 2013, Kazama et al. Coined the term uremic osteoporosis to describe the low bone density seen in patients with chronic kidney disease. And they posited that the presence of chronic kidney disease gives rise to a more severe abnormality than can be expected from normal aging. And they attributed that to the changes occurring from hyperparathyroidism, which basically would be changes in turnover, a predilection for cortical bone loss, and these changes leading to altered mechanical properties, material properties, and microarchitecture. And indeed, we are able to see in this figure the changes in microarchitecture that are demonstrated on an HRPQ-CT, the first one being from a normal individual, the second one being from a person with advanced CKD and associated bone disease, and the third being from a patient with advanced CKD and fractures. In the last instance, we are able to see considerable deterioration of both trabecular and cortical microarchitecture, showing the increased predilection for fractures. So, in spite of understanding the fact that osteoporosis does occur in chronic kidney disease, the component of PTH is what we have focused on as nephrologists. Our treatment of bone disease in patients with chronic kidney disease has basically been a PTH-centered approach. And if we look at the 2017 guidelines, we see that most of the recommendations focus on PTH-lowering therapies. And these include calcimimetics, calcitriol, vitamin D receptor analogs, or a combination thereof. Having uh, having said that, we focus on a PTH centric approach for both diagnosis, understanding, and treatment. Let's pause a minute and see what exactly we are measuring when we test circulating PTH levels. We know that PTH, circulating PTH, consists of intact PTH, C terminal PTH, and amino terminal fragments. And of these, with progressive chronic kidney disease, we know that the fraction of intact PTH increases over the spectrum of worsening chronic kidney disease. However, it still forms only about a third of circulating PTH, the balance being made up of carboxy terminal fragments. And this fraction increases as CKD worsens because carboxy terminal fragments are cleared by the kidney and accumulate in renal failure. And therefore, we have a variable increase in this fraction, which is not predictable. So when we measure PTH and notice high levels, it uh, it becomes a challenge to interpret what exactly the level of PTH measured is connoting in terms of whether this is truly translating to the effects of intact PTH in increasing turnover in bone, or whether it is just an accumulation of relatively inactive fragments. So, in the context of looking at the relationship between PTH and fracture, if there was a robust relationship in terms of um, uh, fracture prevention, we should be able to see a signal when we use calcium mimetics. Epidemiological studies have shown a U-shaped correlation between PTH and fractures, so it's not a linear correlation. So, either very high PTH or very low PTH can be associated with fractures. We have no randomized controlled trials with fracture as a primary outcome and PTH lowering as an intervention. So there is a paucity of data out there. Most of our signals come from secondary analyses of other trials, such as the EVOLVE trial, and these have shown just a modest signal for fracture benefit when we use calcium mimetics. Some studies, such as the Bonafide study, have shown that cinacalcet can improve bone histology. However, the effect of cinacalcet on bone density remains to be clarified. So, clearly, when we are talking about bone fragility and fracture in patients with CKD, PTH is not the whole story. So then, what else may we focus on if PTH is not the whole story? And perhaps there, an understanding of bone turnover becomes important. Um, when we talk about bone turnover, understanding the basic functional unit of the of bone turnover is a requirement, and the bone metabolic unit is the basic functional unit. So the BMU, or the osteon, is the term coined by Harold Frost. Um, and this bone metabolic unit consists of osteoclasts, or the bone resorbing cells, and the osteoblasts, or the bone forming cells. And the actions of these cells are tightly coupled, um, bone resorption leading to bone formation. And you're able to see this bone metabolic unit in this section of bone. To orient you, the blue part is the mineralized bone and the cellular part is the marrow, and the area that we focus on is the bone marrow interface. Now, along this interface, this is the leading edge of the bone metabolic unit, where you see the multinucleated osteoclasts resorbing bone and creating resorptive lacunae. It's like taking a bite out of a cookie over here along the surface. And as the osteoclasts progress along their resorptive surface, you see osteoblasts that are streaming in and laying down osteoid over here to fill in these resorptive lacunae. As we go into the trailing edge, we see evidence of mineralization in the blue areas, starting in the osteoid that's been laid down. And we also see a change in the morphology of the osteoblasts, they being plumper and palisaded in this area and being flatter in the area where their immediate synthetic activity has died down. So, knowing the activity of the bone metabolic unit is important in understanding turnover. And when we are looking at bone turnover, we are basically referring to three processes. One is bone remodeling, which is the coupled process of resorption and formation, and that takes place throughout adult life. Balanced resorption and formation maintains bone mass, and once there is uncoupling of resorption and formation, you get bone loss. During the growth phase in childhood and adolescence, we see less of resorption, much more of bone formation, and that kind of bone turnover is called bone modeling. So, this cartoon depicts the uncoupling of resorption and formation and shows you that you can reach the same bone volume with different rates of uncoupling. So, you could have a low turnover state where you reach the same bone volume much slower than a high turnover state where both formation and resorption are uncoupled, but the rates are much more rapid, and you may end up with more rapid bone loss. The importance of this distinction is that in a person with low turnover, you would encourage bone formation with your medication, with your therapeutic approach. And in a situation where there is a high bone turnover, you would look at approaches that block bone resorption um, uh, to prevent bone loss. So let's come back to our dialysis patients and look at what bone turnover is in them. Bone turnover is largely driven by PTH, as we have discussed. However, the relationship between PTH and bone turnover is neither linear nor consistent. So, all of us would appreciate the fact that clinical guidance employs thresholds, perhaps a bit arbitrary, but it employs thresholds for simplification and for clinical application. Because this relationship is not precise, we have to consider that there are other modifiers of this relationship that may be important in bone turnover in dialysis patients. And we must remember that PTH levels require qualified interpretation, mainly because of the issues with what we are measuring in an assay. Unfortunately, there is no good non-invasive way to track turnover. This is the largest study of its kind by Sprague et al. Of 492 dialysis patients, where they actually looked at levels of PTH or bone alkaline phosphatase in terms of whether these levels, characterized as either low or high, would predict low bone turnover or high bone turnover. And we could take a look at sensitivity, specificity, and predictive value, and none of them are very impressive. So, with the lack of a good non invasive way of predicting bone turnover, we need to go back to invasive methods, increasing the case for performing a bone biopsy in patients on dialysis. Bone biopsy remains the gold standard for assessing turnover and mineralization in bone. And in the 2017 KDIGO revised recommendations, the indications for bone biopsy in patients with renal osteodystrophy was expanded. And the primary motivation for this was the fact that there was a growing acknowledgement that osteoporosis was something that we needed to tackle in patients with chronic kidney disease, patients with low bone density who were at a high risk of fracture, and the inability to treat these patients with osteoporosis medications because we did not have adequate data should prompt us to proceed with a bone biopsy to get as much data as we can. So at this point, I'm going to share two case histories with you to demonstrate how a bone biopsy can provide us information in situations where there is a discordance between non-invasive markers such as PTH or bone alkaline phosphatase or other turnover markers, and where it can be helpful in treatment. So this is a 54-year-old female on dialysis for about 10 years who presented with osteoporosis, the lowest T-score of negative 2.7 at the radius. Her history was significant for a parathyroidectomy 6 years ago when she presented with calciphylaxis. She also had had a gastric bypass 12 years ago, uterine cancer requiring radiation, and she had taken steroids intermittently for psoriatic arthritis and gout. She had a premature menopause but had not fractured in the past. Her labs were significant for a low PTH, deficient vitamin D, for which she was given uh, vitamin D supplementation. But significant was the fact that she had a low PTH that was consistent with her past parathyroidectomy. We went ahead with the bone biopsy, and before the bone biopsy, our clinical diagnosis was this patient has low turnover, possibly adynamic bone disease, given the fact that she had undergone a parathyroidectomy. However, the biopsy came as a surprise, and here to orient you again, the blue part is the mineralized bone, and this cellular part is the marrow. And here you're able to see that there is ample osteoid in the red that is being deposited, showing evidence of bone formation, as well as large osteoclasts carrying out their resorptive activity. And this is actually a resorptive tunnel, which shows that this patient has high turnover bone disease despite having a low PTH post parathyroidectomy. And her fluorescent microscopy with tetracycline labeling shows uptake of tetracycline and good double labels, consistent with the fact that she has high turnover disease. So this patient was treated with low dose alendronate and did well. So we must remember that there are other drivers of bone turnover, not just hyperparathyroidism. Some of them may be CKD specific and they may not be CKD specific. And in this context, we should not forget that patients with CKD can also have primary hyperparathyroidism. Okay. My second patient is a 64-year-old referred from orthopedics for a non-healing femoral fracture. Her past history significant for poorly controlled type 2 diabetes, atrial fibrillation, stroke, aortic aneurysm surgery, proteinuric CKD stage 3, osteoarthritis, but a positive rheumatoid factor, vitamin D deficiency, obesity. She'd sustained these fractures after a motor vehicle accident, and this was her X-ray 8 months later for non-union. She did not have a delayed menopause, but she had lost her teeth in the 40s, showing that she probably had poor skeletal health for some time, and her diet was abysmal. Her investigations advanced, she had CKD stage 3B. She had osteopenia on a DEXA scan. Her diabetes was very poorly controlled. Her PTH was 54, not very elevated. Um, and her bone markers were generous, but possibly there was an element of retention given the fact that they are renally excreted. Her bone biopsy shows osteoporosis. It shows a decrease in trabeculae and thinning of trabeculae and decreased connectivity, a lot of cortical porosity uh, and trabecularization of the cortex, showing osteoporosis. We were not able to get tetracycline labeling because this was an intraoperative biopsy, but this does suggest that she had low turnover. For the low turnover, we started her on teriparatide, and this is her X-ray several months after starting teriparatide, showing evidence of new bone formation at the fracture site. So at this point, I will um, continue on the theme of turnover and uh, go back to the thought that we did consider one of our patients as having adynamic bone disease. And I'm going to spend a few slides talking about adynamic bone disease because um, uh, we consider it as uh, a diagnosis with a poor outcome. And sometimes that fear may be misplaced, mainly because the condition is not well defined. And this may be more um, a, a specter of fear rather than true understanding of a poor outcome over here. We have often read that adynamic bone disease is the most common form of renal osteodystrophy. However, many of the studies that have looked at the prevalence of adynamic bone disease have not looked at histology, but actually gone by PTH levels that were low to indirectly term uh, a diagnosis as adynamic bone disease. And there's therefore a lot of imprecision in diagnosis of adynamic bone disease. Now, we should go back in history to see where adynamic bone disease was described. And this was first described by Sherard in the 80s as aplastic bone disease in the setting of aluminum bone disease. Um, we know that a characterization of this condition is not adequate. Low PTH is not adynamic bone disease, and all low turnover may not be adynamic bone disease. We also know it's a heterogeneous condition, and low turnover can be seen in many, many settings, usually where calcium metabolism has reset itself. And the morbidity of fractures, bone fragility, and vascular calcification and calciphylaxis is not uniformly observed. And we often need underlying comorbidities such as diabetes and the MIA syndrome to actually see these poor outcomes in association of low turnover bone disease. So there are many questions, some of them concerning with relation to adynamic bone disease. And one of them is that if low PTH leads to adynamic bone disease, is there a danger in PTH suppression? Will calcium mimetics lead to adynamic bone disease? Will parathyroidectomy lead to adynamic bone disease? And unfortunately, we sometimes hear soft answers saying that they would. And the concern there is, are we withholding PTH suppression from the ungrounded fear of adynamic bone disease, knowing that high PTH is maladaptive in our patients? So these are questions that certainly need a lot more resolution. Again, in the setting of vascular calcification and its association of adynamic bone disease, is vascular calcification really a function of low PTH, really a function of low turnover bone disease, or is it a function of calcium loading, a function of decreased calcium tolerance, or a function of underlying comorbidity such as MIA? Let's go back to Sherard. And he noted that there was a subset of patients without aluminum who still had low PTHs and low turnover in the bone, but they had no adverse outcomes. And he indeed coined this diagnosis in patients without aluminum a non disease of medical progress. So let me leave you with that thought. And my last two slides are to highlight the curse of renalism that I think all nephrologists should be aware of as our practice becomes more and more interdisciplinary. One of the things that we have suffered from is suboptimal representation of patients with CKD in osteoporosis trials that has impeded the use of osteoporosis medications in patients with kidney disease and patients on dialysis. In patients without kidney disease, we routinely focus on turnover and use that as a guide to therapy. Patients with decreased turnover, we treat them with anabolic agents, and increased turnover, anti-resorptive agents. We are not able to apply the same paradigm to our patients with chronic kidney disease. And even departing from the realm of research and trials, in day-to-day life, something is not right here. In the general population, which is relatively low risk, we measure bone density. We screen women over the age of 55, men over the age of 65 with a bone density. We have specific quantification of risk for fragility fractures. Our approach is preventive, targeted. We have novel agents. However, in our own CKD population, which is high risk, we have no effective risk prediction system for fractures. We have no screening recommendations, although they are the same age group with CKD as in the older population without kidney disease. It is the occurrence of fragility fractures that provides a critical trigger for evaluation rather being in a preventative mode. And we rely on expert opinion rather than data, where biopsy and TMV parameters are used as qualitative surrogates for fracture risk. And we do not have data to back up use of novel or even older agents. So something is not right here. And I will leave you with that thought at the end of my talk. Thank you.